ago, where they had individual components of the system, but they were not coordinated into one unit. So what they just did is just put them together under an emergency care system framework. And even the WHO recently, as of last year, came up with an emergency care system framework because they also realized the same thing, is every country has hospitals, has ambulances, has maybe a number, for example, but all of these are independent. But for this system to actually provide emergency care, for this system to provide timely emergency care, because in emergencies time is an issue, then they need to work together as a system. So the WHO came up with the emergency care system framework, which then puts these components together. And for us in Kenya, what we need to do is put all these components together: the Health Act, the Constitution, the ambulance services, the 719, the emergency centers, all these things put together under a system that then we can say this is our emergency care system, modeling what the WHO has recommended as an emergency care system framework.
And I think COVID actually gave us a scenario as to how this is possible.
Yes.
And we actually tried it. I don't know if it's actually here to stay.
Exactly. I hope it's here to stay, because that was actually what we did. We took a number, we put some ambulances, we now dedicated facilities to manage COVID. So it is that system that, as we said, we tried that we need to now look at how does this system then become more robust to cater for not just COVID patients, but also all other emergencies. And then what other investment is needed then, once we've established the basic framework of the system, then now look at what investment is needed to make sure that the different components are strengthened. So is it the ambulance that need to be strengthened? Is it the emergency centers that, as Dr. Mongera mentioned, the emergency centers need to be strengthened in terms of their systems? But without understanding what the system looks like, then we'll keep just doing haphazard things all over the place without actually providing standardized emergency care.
Now, Dr. Olweni, before I take a short break, you talked about the importance of relooking how the private entities can be able to do business but still provide this critical care. In other countries, it seems that we cater for you before we ask questions later, so to speak. What is it about the Western world that works for them that doesn't apply here?
I think mainly it's the issue that I raised earlier about not paying for the service at the point of care. You have to have a pooling mechanism where people either have some form of insurance or other means of paying, so that you're not being asked for funds at the point of receiving care. That's what's important. But that having been said, I have to emphasize here that hospitals are still obligated to assess, to stabilize, and then to transfer. So that is not, if anybody does anything contrary to that, that would be ethically indefensible.
Very well said. And when we come back, we'll be talking to somebody who was actually part and parcel of that movie back in 2017 called 18 Hours, which was in remembrance of Alex Madaga, who stayed for 18 hours in an ambulance and actually lost his life as he awaited this critical care. But before we get to it, we had asked you the question of the day. Do you know someone, or have you been turned away from a healthcare facility while trying to access emergency care? That hashtag is new normal. Mark Mkutu says, do we as a nation have an emergency medical care policy? Well, that was actually released last week, and we pray that this is what will help us now catapult all these other issues that have been put to the fore. Kipchir says, can all the poor Kenyans access private hospital services? Think about the common citizen, and that is why we are not only talking about the private hospitals. We have mentioned the importance of equipping our public hospitals and our public services. When we come back, we discuss more about our emergency medical care in the country and, of course, hear from you too. Remember, that hashtag is new normal. Stay with us. Thank you for staying with Your World. My name is Gladys Gashanja. Our conversation this morning is emergency medical care. And to help us with this conversation, still in studio with me, Dr. Benjamin Wachira. He's the president of the African Federation for Emergency Medicine and also the founding director of the Emergency Medicine Kenya Foundation. In the other studio, Dr. Timothy Olweni, who is the Secretary General, Kenya Association of Private Hospitals. Via virtually, that is Zoom, we have Commissioner Kagwiri Mbogori, who is a council member at the Kenya Medical Practitioners and Dentists Council, Dr. Ann Gathoni, who is in charge of Health, Environment and Sanitation in Lamu County, Nerima Were, who is the Acting Deputy Executive Director at KELIN, and next to her, joining us virtually, is Kevin Jue, who is a film director, and his role in this conversation is coming up in a moment. But before we get to it, in March of 2018, it was reported that a county assembly member from Embu had used his 4.5 million shillings car grant to purchase a fully equipped ambulance for his community in a bid to boost access to affordable healthcare. Maurice Moshiri Nyaga alias Kolo, a first-time MCA from Kirimari, said the ambulance is meant to boost access to quick healthcare services, particularly for residents living in informal settlements who cannot afford an ambulance when they needed transport to hospital.
MCA Maurice Moshiri says the ambulance will complement the services offered by the county government and ensure residents have proper and first-hand health care. He says the ambulance will be parked in strategic areas of the ward that hosts Embu Town, the county headquarters, and will only be a phone call away.
Mtu akigonjeka anashindwa kwa afford ambulance ya APGH. Nikaomba mimi kama mheshimiwa wao kando na county government tatoa pesa yangu ya mfuko ni wanunulia ambulance ambayo itakuwa inawasaidia 24/7 for free within Kirimari.
Itaisaidia wale wagonjwa ambao hawezi afford, wengine labda watakuwa hata wakibebwa free nayo. So sisi tunafurahia sana juu ni kama ametupatia aid ya kusaidia wale ambao hawajiwezi.
Meanwhile, residents of Embu Town have raised concern about some medical personnel in public hospitals attending to patients while drunk and sale of government drugs in the black market.
Kila kitu iko, juzi tulifanya scanning ya kichwa na tukaona hiyo hospitali ni kubwa, lakini ukienda pale unaambiwa uende ukapigwe picha outside the hospital, which is very wrong. Wananchi wenzetu hawana pesa za kuenda kufanya hiyo kazi. Kwa hivyo tafadhali, kama hospitali iko equipped, wacha mambo yote ifanywe hapo.
There are also complaints about local chemists selling government drugs meant to be given to patients in hospital. Residents want modern equipment at the local public hospital, and they have, however, loaded their MCA for buying an ambulance from his own pocket, calling on the government to increase the number of ambulances in Embu.
Okay, now that was back in 2018, and I just asked Dr. Wachira if probably we have a status reporting as far as how the counties are faring on when it comes to emergency care services.
Yeah, so in 2018, 2019, we actually conducted some research to try and identify which are the emergency care centers, public emergency care centers across the country. And we went from county to county trying to identify which are the facilities that are open 24 hours a day and have theater services also available within the facility. And from our assessment, there were approximately 200 facilities across 44, we still have to do 3 counties, across 44 counties that actually are emergency centers in the sense that they're open 24 hours a day and have theater capacity, so they're able to take patients straight to theater. In some counties, they actually have well-developed ambulance systems. Makueni, for example, Kiambu, Wajir, they actually have established their own ambulance systems within these counties, and this is actually commendable in terms of being able to provide the care that the community requires. So there's actually a lot of work happening in the counties, and some counties are definitely more ahead than others in terms of putting in the appropriate emergency care systems. And for what we're doing now for us is working with these counties to see how do we strengthen all of these counties so that they're all at the same level of provision of emergency care.
Now, Nerima, let me bring you on this one. Most people would see an ambulance and say, ile ata siwezi make, so I cannot afford that. So when it comes to emergency care, the next to go-to person is a boda guy. So in this case, even if I'm paying my NHIF and I have my cover, how do we ensure that everyone can actually get the luxury that comes with an ambulance getting you to hospital probably faster and safer than that Buddha guy?
that speaks to training and clarity on obligations. So the national government and the county governments have to work together in terms of clarifying what obligations are in place for ambulance services. And that has to speak to private care providers as well. So it's not enough that you have the ambulance. How do you use it? And you do have an obligation. This has been spoken about through and through. It is a right. So I know that there is a question of cost, but you cannot be charging when it's an emergency service. You can't. Even with an ambulance, you have to at least specifically wait to finalize the transaction before you seek to charge the patient. So obviously most people won't even try because they have experiences with ambulances in Kenya, with hospitals in Kenya. However, the national and county governments have to work in coordination in terms of availing funds, training the people who have to provide the services, and then making it clear what the obligation is. So if you are going to provide this service, you're licensed to provide it, you must do it in a certain way. That is, put the patient's needs first and then seek to be reimbursed later. The next thing would be to ensure that Kenyans understand this. It's not enough to have services available that Kenyans don't understand. And this speaks to more than putting policies in place. You have to roll them out in a way that everyone understands what is available to them, what their responsibilities will be, and what the government has in place. Often we say we have very good laws and policies. The implementation is where we fall down. Consistently, this has been the problem. And part of why we fall down in implementation is because people don't understand what the government is obliged to do, what private care facilities are obliged to do, and how they can access the services. So if we don't have a public awareness campaign going in line with some of these policies, we'll continue to have the same problems. The government has an obligation to increase awareness and knowledge around health and health information, both as promotive and preventive health. So if they don't invest in this, then we will have people who are not able to hold them to account for that.
Okay, now health is a devolved unit. Let's hear from Lamu County. Dr. Gathoni, are you intentional about sensitizing your residents to understand that these services that you are investing in are actually within reach?
Yes, we are very intentional. One of the things that you need to know about health, we do not operate in a vacuum, in that we need our communities to own what we are doing. And that is where the issue of sensitization and what we call communication, especially on health matters, comes in very critically, so that they understand where we are. But of most importance is to own the process. When they own the process, as they utilize the services, they are also going to get aware that their voices can be listened to and they can be heard, they can make suggestions, and they can take these services as their own because we are delivering to them. So in Lamu, what are we doing? Health being a devolved function, particularly on the aspect of delivery of health services, the ministry was largely, or the national government was largely left with the aspect of policy development. But in terms of delivery of services, we on the ground as counties are the ones that are delivering services to the mwananchi. We are the ones who know where the shoe pinches the most. And as such, we have had, the Daktari has mentioned about the intentions that the counties have put, especially in investing in ambulance services. Actually, the move now is towards having ambulance services at the community level. We know largely ambulance services have been at the facilities or rather at the hospitals. And that again affects the response time. And we have had, or rather we have learned lessons from some areas where ambulances have been placed within the community. That improves ownership, but the other thing also, it also improves in terms of response time, so that we don't have these patients have to wait long for this patient to come, for the ambulance to come from the facility, pick up the patient from the community, and again back to the facility. So although it comes also with the challenge of responsibility, you know. We mentioned the issue of if you have to place the ambulances in the community, it requires a huge needs of ensuring that this community is also responsible, so that these ambulances are also used when they're needed, because it is a resource. In Lamu, it is a process. We haven't gotten there in terms of placing the ambulances in the community, but it is one of the things that we are intending to have, or rather to implement in the coming future. But among that, in terms of, I mentioned that we have been providing ambulance services for free. And to make this, to improve this in terms of access for the patient, one of the things that happened as a flagship project in the county was the financing aspect. We brought in NHIF, and about 2/3 of the population is covered under the NHIF, so they can access facilities within the county as well as outside the county when it is needed. So it is, as I mentioned, investments, especially for the counties, is very huge. If we look at the last 7 or 8 years of devolution, there's a lot that has happened in terms of investing in health. And I'm sure as you get along, we're going to get at a better place in the coming years. And in this particular year with COVID, there is a lot of intentional investment that has happened.
Yes, and we'll talk more about that even as we think about realizing UHC, universal health coverage in this country. Now, in October of 2015, Kenyans woke to shocking news of how an accident victim had spent 18 hours in an ambulance bleeding in his brain just because one of the hospitals in this country did not have an ICU bed. Now, a group of Kenyan filmmakers came together and made a film based on the tragedy in order to raise awareness of appropriate bystander response behavior and actions. The film captures the reality of the healthcare scramble in Kenya. The 1 hour, 85-minute full-length film, 18 Hours, follows a rookie paramedic who survives 18 hours in an ambulance for the life of a road accident casualty who's denied admission into hospitals.
I have a priority 1. Suspected head injury secondary to a high-speed hit-and-run. Unresponsive adult male, about 20 to 30. Might have traffic up ahead.
We need to know where you are. Okay, Esther, you have to slow down. Just take a deep breath. Now tell me, what happened?
So what do we have?
Pedestrian involved in a high-speed hit-and-run.
How long ago?
That's all we have.
My name is Zach from Raven Paramedics. Sir, I'm with the ambulance. We're here to help, okay? Raven Paramedics were expected.
We don't have an ICU bed.
What? We have a patient who's in dire need of emergency care.
All our 21 beds are fully occupied.
We need to get moving and get to a hospital with working doctors.
We need to sign off this patient to a hospital. Trust me, you don't want your name in the news with blood on your hands. How many lives do you think I've saved before?
Do you count? I don't know.
Exactly my point. Many.
Kwani Mungu ako wapi? I don't want his will to be done. Kama hiyo will ina take away what matters to me.
I am not giving up.
And I am not asking you to.
You can treat my husband. That is the least you can do.
I'm a paramedic. I know my job. No entry on the left side.
He has internal bleeding on the left side of his brain.
Say something!
8, 9, 10.
Clear!
18 hours indeed, inspired by true events, even as it captured or reenacted the last moments of Alex Madaga's life after a tragic road accident. He lost his life in an ambulance 18 hours after that road accident because hospitals could not take him in. And now we're joined by Kevin Joy, who is a film director, and he is the man or one of the creatives behind this amazing film that brought to the fore the reality of what most Kenyans are living today. And thank you for joining us on this one. And why did you decide to reenact those last moments of Alex Madaga's life?
Thank you for having me, first of all. And like every Kenyan, when I read the story in the newspaper back then, it was something that, you know, was quite disheartening. And I felt, you know, how can this happen in the city, the biggest city in our country, in Nairobi, where, you know, it's a metropolitan, all services should be available for all people. Then some days later, we kind of had a similar situation with a neighbor where also a neighbor was attacked and had a similar experience where hospitals were not taking him in because he didn't have cash at the moment and he didn't have insurance. So, you know, those things just hit deep in me and my team at Rock Pictures. And I think that was the motivation of, you know, what can we do as artists and how can we help, you know, shape a better tomorrow. So that was kind of the genesis of the story, yeah.
Okay, and it definitely had a lot of eyebrows raised after it was released, and you got accolades after doing this. What are some of these?
Yeah, so the film did quite well, and I think our main goal was how does it help shape our society? That was always the main goal. But along the way, as filmmakers, you get to go to, you know, get to see it in the cinema. That's a whole experience by itself. And other accolades were, and I think the biggest one was the MVCA in 2018 when we went to Nigeria, which is the biggest film award ceremony in Africa. And yeah, we won the best film in Africa that year, which was the first time for Kenya. And yeah, that was a big moment for us as filmmakers.
So even as you were going to these different countries, getting these accolades, what did people say? Did they, you know, like identify with the movie in their own countries?
And I think that's actually the beauty of cinema and the beauty of art is it cuts across borders because art just communicates human emotions. And most people in places where we traveled and showed the film, especially in Nigeria, is they understood what we were trying to communicate because they have their own system there. They have their own issues with their emergency and healthcare system. But at the core of every story is an emotion. And I think that was what made them connect with the story even more. Yeah.
Okay, now the film actually helped push the Kenya Health Act of 2018. How was that for you?
Well, that was a big thing for us because, as I said earlier, that was where we wanted it to its impact. That's where we hoped the most impact will come from. And that was not even mainly us, the artists. It was the people around the film, like Emergency Medicine Kenya Foundation, Dr. Benjamin, Irongo, Houghton then, from Chapter 1, who are also partners in the film. And that was their main goal as well, is to how do we take this piece of art and help amplify an issue in our society and hopefully get a change with that. So that was a team effort, and it was definitely a plus for us.
Apart from reenacting the last moments of the late Alex Madaga, you also took time with the film to show what emergency care personnel go through, right?
Yeah.
And was it a learning point for you?
So one of the things we tried to do in the writing and making the film is just not make it an exact replica of Alex Madaga and Brian Ochieng, who was the paramedic. We also tried to see what are other components in our emergency healthcare that we can instill in the film. So like you saw from the trailer is we have two paramedics in the film.
Yeah.
And they are both fictional, yes, but we are trying to show different ideologies. For those who've watched the film, the two paramedics have different ideologies. One is really optimistic about changing the system, optimistic about doing things the right way, while the other has been in the system for, 20 years or so. And so he's used to seeing bad things happen, and he somehow becomes numb to them, and he doesn't go the extra mile in trying to change things.
And it was actually a very good film, and one that keeps reminding us of some of the things we need to keep investing in. And that's why we're having this conversation now. Dr. Wachira, I saw you laughing when he mentioned about the situation in Nigeria. You worked with the crew in putting together the 18 Hours movie. What is the status in other African countries?
I was laughing because last week during the 5th African Conference for Emergency Medicine, we had a lot of Nigerians, and they were all lamenting about how bad their system is and how they need to actually improve their system. So when you mentioned Nigeria, I was like, yes, this is the same comments we were making yesterday, last week, sorry, about the emergency care system. So we have, I'd say there are countries that potentially we could copy from or we could emulate. Ghana, South Africa have very good emergency care systems. Egypt also has a good emergency care system. But interesting enough, even our neighboring countries, Uganda has been doing a lot of work in building their ambulance services and building and training the ambulance personnel and building a public ambulance system. Rwanda has been doing the same. And Tanzania, I know, Tanzania right now, it's really doing a lot of investment in building the regional emergency care centers. So that not every emergency has to be brought to Dar es Salaam. So they have Mbeya Regional Center, they have one in Arusha. So they're building fully functional emergency care units in different regional areas around the country, so that all emergencies are being handled at the regional areas rather than all of them coming towards the city. So there's a lot of work going on across the continent. And also, of course, South Africa, as I mentioned earlier, about their systems being well designed. Yeah.
And we have spoken about how finances seem to be the obstacle to where we're supposed to be. So what have these countries done when it comes to the financing of the same?
So a lot of which is also boils around social healthcare systems. And I think that's the same discussion we've been having here. And I think Naima also mentioned there's the emergency care fund that was established in the Health Act 2017 that has never really been implemented. But the idea behind this was to be able to ensure that people can access emergency care without necessarily either becoming financially bankrupt or even when they do not have the resources. So in many countries, they've actually enshrined funded emergency care such that people can actually call an ambulance and receive ambulance services for free. Okay, as part of the public, and when you get to these facilities, then the emergency care is actually provided for free, and this is reimbursed by the government as part of the emergency care services. I know, like, for example, in South Africa, what the government has even done is, because its capacity is limited as a government, they've actually incorporated the private healthcare services, the private ambulance services, and the private emergency care, emergency departments, and put in provisions such that if you respond to an emergency as an ambulance, for example, or you provide emergency care as a facility, you will be reimbursed at the same rate the public hospital gets reimbursed. So you're not being paid at the private rates, but at least you get reimbursed at public rates. So this has allowed a lot of the private facilities to actually happily manage emergency cases, because they know they're not doing this for free, and they are providing an essential service that is mandated, again, also within their constitution. And they know very well that the government will reimburse them. And it may not be to profitable levels, but at least they will get some reimbursement. And this is one of the things that we actually need to look at, even through maybe NHIF, so that if emergency care is provided by a private, because it's not, in our setting, I don't think it would be possible for the government to provide all the emergency care services. Like right now, majority of the ambulances are private.
Yes.
But if there could be a reimbursement model that's agreed upon between and through public-private partnerships, then I'm sure many private healthcare providers, either ambulance services or emergency centers, would be more than happy to open up their doors to more emergency cases coming through, knowing very well that they will be able to at least meet their costs to provide this emergency care.
Dr. Olweni, is this possible? Is this something that you're probably perhaps in talks with the government about?
Yeah, I think the NHIF has been proposed as a vehicle to be able to finance emergency health service in facilities, and I think they have the infrastructure because they already accredit all licensed institutions. So first of all, we're ensuring that all the institutions we're talking about have been vetted and have got the capacity to provide the emergency services. However, NHIF still primarily provides this service to their members, and that poses a challenge, and especially in settings like in the COVID pandemic, where there's a lot of financial constraints, you've got a serious drop in the number of especially voluntary contributors. So for example, you've got a lot of people out there who also don't have any form of insurance at the moment. So I think what is required is for the government, through this emergency fund, if it was set up, I've not seen anything on the ground to support the fact that it does exist.
Okay.
But if the government can be able to do that in terms of being able to provide that funding and use NHIF as a mechanism to pay for all Kenyans, regardless of whether they're NHIF members or not, and that, of course, will help in terms of being able to get people access to healthcare.
And Dr. Wachira mentioned about that whole partnership with the government, and you can be reimbursed, maybe not on the private level, but at least something that is, worth your time, if you were to put it that way. Is it something that's possible?
Yet it's something that is possible and something that private hospitals are very willing to embrace, because let me be honest, at the moment, there are a lot of private hospitals do incur expenses which are not reimbursed at all. And I said we're ethically obligated to be able to provide this care. And I think, unfortunately, a lot of the cases that make it in the public domain are those that are not handled well. Private institutions are by no means a homogeneous set of institutions. So you have some that are going to comply with the law the majority of the time. There are some, of course, who again might lean the other way. But that having been said, there's a lot of resources that are spent by private hospitals which are not reimbursed, and that's why it becomes necessary not to disincentivize them. For example, when you talk about ambulances, I think this term sometimes is used so loosely. In fact, it can only be described sometimes as embroidering the truth beyond recognition. Because if an ambulance is purely a transport vehicle, the truth is, you're better off taking the boda or some other means you'll get to hospital faster, other than waiting at the scene for something which is going to do the same thing. So ambulances, by definition, are supposed to provide care from the scene and during transport all the way to the hospital. So in the absence of those vehicles being equipped, and so you have a lot of ambulances which are called ambulances in this country, but if you, with all due respect to them, a lot of those are purely transport vehicles, and that function can be met by using other means.
We hear you, and we'll come back more on where we need to go as a country and what else needs to be done to ensure that every single Kenyan can actually be able to access quality emergency medical care. And I'm told before we take a short break, we still have some feedback coming from you, even as we asked you if you know someone or have been turned away from a healthcare facility while trying to access emergency care. We have Shem Nyeribo, who says it's not an area of concern to politicians who think they will be always in Nairobi to receive treatment. Shem, we hear you loud and clear. Electra Frost says, do Kenyans get this care really well? It actually does exist, and unfortunately the reality of the same is only real to us when we need it. That is the unfortunate truth. And that's why we're talking about this morning, to ensure that this is actually set up in a way that whenever you will need it, it will be there to cater for your needs. We'll be right back. Thank you for staying with Your World. My name is Gladys Gashanja. Before we get back to our conversation of the day, emergency medical care, giant flowers and plant topiaries, some featuring popular Disney characters such as Mickey Mouse and Donald Duck, welcome visitors to the Dubai Miracle Garden, the world's largest flower garden, after it reopened its doors for its 9th season. Now, the managing director of Dubai Miracle Garden says the Dubai Miracle Garden is the largest flower garden in the world, which contains millions of flowers. About 150 to 200 million flowers are displayed for visitors. It has achieved a Guinness World Record through the Emirates Airlines A380 aircraft. It is a life-size design of the Airbus aircraft, 1:1 scale in all its dimensions. Approximately 40,000 basins of plants were hung off the structure. To something that touches on our conversation of the day. In the Italian region of Lombardy, the volunteer ambulance drivers of the Croc Bianca Association, who provide emergency aid and transport patients with the virus to hospitals, are battling the second COVID-19 wave. And now Italians largely supported and respected the quarantine early in the year, but the prospect of another punishing lockdown has sent some of them on the streets. In the northern city of Bergamo, the epicenter of the first outbreak, several hundred protesters demonstrated in front of a mayor's home, hurling smoke bombs and shouting liberty. Mayor Giorgio Gori wrote on Facebook that unlike during the first quarantine, when images of army trucks in Bergamo transporting coffins from the overflowing morgue were seen around the world, there is more tiredness and more distrust this time round. Elsewhere, pressure on hospitals grows in Naples as the number of patients arriving at the emergency department with suspected COVID-19 infections increases. Now, the number of confirmed coronavirus cases in Italy has passed the symbolic 1 million mark, while almost 43,000 people have died. The Italian government imposed tighter restrictions on another 5 regions as it tries to stem escalating new cases of coronavirus while still resisting a nationwide lockdown. A total of 7 out of Italy's 20 regions are now so-called orange zones, signifying medium-high risk after a new decree signed by Health Minister Roberto Speranza. Another 4 regions, among them 3 in the populous north, which includes the financial capital of Milan, are subject to even tighter red restrictions, with most shops, bars and restaurants shut and residents' movements restricted. Now, back to that conversation of the day, emergency medical care, and I'd like to hear from Nerima on this one because it's being put out there that there is a flip side to this conversation, an issue of people abusing their right to emergency medical care, in that there are those who ignore pleas to be taken to a public hospital to get these services and insist they have to be taken to a private hospital. Your comments?
So my comments around that are quite simple. You have to think about it as pooled resources. So that's the hope that we'll have pooled resources. And the more it costs for you to access your treatment, the more you're taking away from other people. So health is a public good, and the Constitution does mandate that it's provided to you, but not just you. So the aim is to have as many people covered with the available resources. And if you insist on a private hospital, despite not having the finances to pay for that by yourself, what you're doing is pulling away from the pooled resources and taking away from other people. And while the state does have to provide the service for you, we all have a duty to defend our Constitution. So if we're not allowing for our state to do so meaningfully by ensuring the resources are being spent in a way that is to the benefit of everyone, then we are taking away from the Constitution as well as Kenyans, and we have that duty to defend it as well.
Dr. Olweni, do you deal with such cases where clearly you can see this person could have gotten the help they needed from a public hospital they passed on the way?
Care facilities is disproportionate in the sense that, first of all, they don't have they're not as resourced as public facilities because they don't get funding from the exchequer. And secondly, there's a perception that the people are going to get better quality service and from private facilities. So that does happen because people selectively choose which facilities to go to, and that is within their right. So we end up managing patients who are presented there by choice, and at some times, unfortunately, also they don't have the ability to pay. And that's why I said we still have to fulfill our mandate and our obligation in terms of being able to assess these patients, to stabilize them, and then at that point, if they're still not able to pay, and I think we should be able to transfer them to a facility which they can afford.
Dr. Gathoni, do you deal with patients who you really need to help them out, but they're insistent they only need this help from a particular health facility?
Oh yes, it happens. One of the challenges, rather problems that we have suffered from as a public health sector is negative perception. You know, the imagination by the public that the kind of care that we are offering in the public sector is not up to standard, or we're not doing good things. Unfortunately, we have not had platforms where good stories of what the public sector is doing are not, are publicized. I think a lot of times what we hear in regard to the public health sector are negative stories, you know, where something happened to a patient here and there, and that becomes a headline story. And of course, that hits very negatively against the public health sector. It also erodes on trust from the community. But there's a lot of good work that is happening in the public health sector. We need to be aware that more than 80% of the population is accessing health services from the public health sector. So we have a lot of good work that is happening. But of course, again, for Kenyans who feel they are slightly endowed, especially in terms of finances, they believe they can only get good care from private facilities. I am one of the persons who advocate for, having good facilities in our public health sector, and also pass the same information to the community, so that you don't have to really go thousands of kilometers away to get a service that you would have gotten at your nearest facility. And it is something that we need to keep telling our communities, even as we continue investing in a public healthcare system to improve it from where we are. We need to let them know of the kind of services that they can get, and as Dr. Ashura says, what is it that is available here and what is it that you cannot get? And that can build trust when you communicate appropriately. It can build trust and also ensure that our communities are well informed on where they can get the services from the public health sector. Of course, the other challenge is the numbers. We are really dealing with huge numbers, and people are scared of coming to wait, and interacting with people from all nature of backgrounds and all that. There is a huge challenge. But the public health sector, as I've mentioned, there are a lot of good stories and a lot of good work that is happening. Possibly has not been publicized much. So there is a lot, again, in terms of emergency care that people can get without traveling thousands of kilometers to look for it in the
Very well said, and clearly the mandate to you is to ensure that Kenyans know what you're doing. And before I let you go and move on to Dr. Wachira, I hear there's a question for you, Dr. Gathoni. If you can have that on. Mwangi Joseph says, would you kindly ask Dr. Gathoni from Lamu, where we still do not have even a single ICU or even an oxygen plant in Lamu County? Our people have been suffering a lot since the only referral that has an ICU facility is in Mombasa, which is over 300 kilometers away from Lamu County. Dr. Gathoni, this is somebody who is not very happy with the infrastructure.
Sure. The public health system, and Lamu in particular, and of course I would mention a lot of the counties. Before devolution, we know that referral services, especially for specialist services, and a lot of other services are only available in what was then level 5s. The then district hospitals had very minimal investments in terms of what kind of services would be able to be offered in the facilities. And we know even as recent as before COVID, the only facilities in the public sector that had ICU beds or other ICU facilities were only a few level 5s and level 6. That included the major centers that we know that they then called provincial hospitals before devolution. And some of them did not even have more than 2 beds, which means patients had to be transferred as far as Nairobi from very far-flung areas to access ICU services. So what has been happening in the recent years? There has been intentional investment to ensure that we increase our ICU bed capacity. And as I mentioned that COVID, as much as it has given us a lot of challenges, has also been an opportunity to invest. What are we doing in Lamu? Based on our population and the epidemiological modeling that we have been using, we are in need of 3 ICU beds. As I speak, we have some 2 ventilators underway that are coming and some 2 beds. We have an additional 3rd one. So at the moment, we possibly have just about 1, but you're looking at putting about 3 at the county hospital and 3 at mainland hospital because, again, of issues of our unique geography, which is going to give us a total of about 6 ICU beds in the coming days. We have also had the issue of oxygen, and I think I mentioned it when I started talking. Oxygen has been a major challenge, largely because oxygen as a commodity is an essential body commodity that should actually be available from level 2 of our healthcare facilities, that is the dispensaries. But that has not been the case. For long, oxygen was only available in cylinders in district hospitals and was only available for theater patients. So what are we doing as a county? We have had intentional investment to improve our oxygen facility in our hospitals. As I speak, the county hospital has received, I think we have postulated a need of about 20 large cylinders in a month. Of course, that has gone up again with the COVID, but we have had additional investment in oxygen. We are in the process of acquiring 2 oxygen plants at a cost of 40 million Kenya shillings. One will go to the county referral hospital, and the other one is going to go to Peketoni Sub-County Hospital, which is a facility on the mainland, so that it can take care of the mainland population. So that there's a lot of work that is happening in progress. We have an ambitious project of actually getting oxygen all the way to the dispensaries to ensure that the dispensaries have access, or rather have 2 small or medium-sized cylinders of oxygen, so that when you have a patient from the community who requires oxygen, he doesn't need to be transported to the sub-county hospital to get to access it. They can access oxygen at the primary healthcare facility and then be transported while already receiving the drug. Then, we have what we call continuum of care. So I want to assure my Lamu residents that we have a lot of intentional investment to improve from where we are. And in this year alone, again, I want to assure that we have done a lot, and there's still a lot that is going to happen before the end of this financial year to ensure that we improve our facilities.
All right. And Dr. Wachira, when she says it's an ambitious project to have the oxygens in the dispensary, it goes to rubber stamp the fact that not all healthcare facilities are emergency medical facilities.
Yes.
Explain that.
So the thing is, to provide a functional emergency department is a real investment, okay, in terms of the equipment required, the resources required within the facility, and the human resource in terms of trained personnel available at that facility. And it would be impossible to expect every single facility from a level 1 all the way to even the lower level facilities to be able to provide emergency medical treatment. And that's why it's important, and part of what we're doing in the project is to define which are the facilities that are able to provide emergency care. And these are the facilities that the county then needs to invest in to make sure that they have the appropriate resources and equipment. And what we look at from a population distribution is to make sure that everyone within that county, for example, should be able to access one of these emergency centers within at least an hour at best, but maximum 2 hours from what the WHO recommends, so that no one has to travel such long distances to access emergency care. So even at county level, there's a need to look at, and that's what one of the projects we're working on, is to make sure that we are able to define and the public knows, because part of the problem is sometimes the public will go to the nearest healthcare facility.
Yes.
The nearest healthcare facility is a dispensary. If you're having a heart attack, there is nothing that dispensary will actually assist you with. You need to, and especially for example, a heart attack, time is of essence. So the time taken for you to go to that dispensary, then the dispensary has to figure out an ambulance to take you to their emergency center. That's actually wasted time. But if there was a system, and this is one of the things that we want to emphasize, is that there's a need for us to define what are the emergency centers and the public to know which are the emergency centers. So when you're having an emergency, whether, and this could be both public and private, then if you're having an emergency, you should be going to the nearest emergency center, regardless of whether it's public or private. And from there, then you're guaranteed to receive the emergency medical treatment, because the facility has the appropriate resources, has put in the processes, as one of the panelists mentioned, is when you get to the facility, if you're having an emergency, you should not be put in line to wait, okay? You should be able to get priority. You should be able to be prioritized to get the care that's required. And this comes into the design of the emergency department. So an emergency department is a purposefully built department that has all the appropriate resources, trained personnel, and processes to ensure every single emergency is treated in a timely manner to save lives.
Okay, now we need to bring this conversation to a close, but I'd like to hear parting shots as far as how we can ensure that emergency medical care in this country, as we said earlier on, is one that is available, affordable, accessible, and acceptable to all Kenyans. And I'll start off with you, Nerima.
Thank you, Gladys, and thank you so much for having me. Let me start by saying that. For my parting shot, I would note we need to do more than pass laws. Progressive realization is not an excuse to drag your feet over decades on putting things in place, and that's what's been happening both at national and county level. We have the progressive realization caveat with Article 43, but that does not mean that you can wait forever to do something. And I think the High Court in the Mutigo case said, you have to show the steps that you are taking conclusively to prove that you have done your best. And that's not been happening. we're not seeing the steps. We're seeing a policy 10 years after our constitution. We're not seeing the fund despite the Health Act being put in place. We're not seeing any clear partnerships between private and public facilities to ensure that people can access care wherever they need to access care. And we're not seeing a concerted effort to make NHF the vehicle for pooled resources towards health. So we need to do more than pass laws as a country. We need to hold our governments accountable for more than passing laws. The executive has a duty. The judiciary comes in at the last place. However, if we just pass the laws and sit back, Kenyans will be where they were 5 decades ago.
Okay, we hear you. And thank you for your contribution. Dr. Olweni, representing the Private Hospital Association, your parting shot.
I think in closing, I'd like to say that the social responsibility for the progressive realization of health is a responsibility of the state. And that falls squarely on the state. And secondly, if there are any funding gaps, which like what we have highlighted earlier, those funding gaps should be addressed through programmatic action. There's no reason why we shouldn't take legislative action through Parliament, for example, to be able to have a fund akin to CDF so that it can be able to fund emergency healthcare. And then again, individuals also have to realize that they have a responsibility to their health. I think there's not enough mention of how individuals also have a responsibility directly for their health, but also indirectly through exercising their democratic rights so that they can be able to have leaders who are sympathetic to their concerns.
And Dr. Gathoni, you're representing the public sector. Your parting shot, briefly?
Now, as we know, health is a capital-intensive venture. It takes in quite huge resources. As counties being the implementing agencies, we have seen a lot of us in the counties investing up to about more than 30% of our budgets is going towards health. Health being one of the main functions that the countries are having. And as I've mentioned, there is a lot of deliberate investment that is going on. And I want to allow the president, health has been one of his big 4 agendas. And recently we saw him launching what we call the universal health coverage. There's deliberate effort from the counties as well as the national government to invest in health, to ensure that every citizen from the lowest to the highest can access quality health without having to undergo very serious injury, especially in terms of finances. So we are working hard in the public health sector, and we thank the collaboration that we're having with the national government, especially in regard to the realization of the UHC. And we're going to see this in the coming days, because eventually we want to ensure that we have a social health insurance framework that is going to ensure that we're able to deliver as a public health sector. And I think this is going to bring everybody on an equal level in terms of what we can deliver as a country. There's much that we can achieve, and we all mean it. It is very, very possible. Thank you very much.
Thank you, Dr. Gathoni. Now let's bring in Njue. You are here representing the Mwananchi. Now that you brought to us such an amazing movie, 18 Hours, looking at it from that point of view, when you think about emergency medical care, what are your expectations?
So my expectations are that we move forward. As a country, let's not be at the same place we were when the case happened, which is like 4 years ago. So my expectation is both the public sector, the government, private sector, all the hospitals should all play a part in making our society a better place to be in. And also, we as artists, and we have a role to play in our society. We have a role to provoke thoughts. We have a role to encourage. So I think someone mentioned about not just highlighting bad things. So we as artists also have a role in ensuring that we promote good values. We show the positive image of our country. So I think that's where we fit in as artists. We have to do both. We have to be thought provokers, and we have to be, people who spread love and peace and joy.
Excellent, excellent. And thank you for joining us on this conversation. That is Kevin Njue, film director behind 18 Hours. And actually, there's somebody who was asking, where can they watch this movie? Do you have it somewhere?
So, yes, the movie right now is currently available on video on demand. That's Showmax. So if you have a Showmax subscription, you can go on there, log in and watch. It's available there.
All right. Thank you for your time. And as we said, we saw the first ever Kenya emergency medical care policy, launched by the Ministry of Health. Dr. Wachira, you have been in this space. Where can we go with now the policy in place?
So I think one of the things, and I'll quote a senior colleague who mentioned that emergencies will continue to happen whether we create systems or not. That's just a fact. And I think now that the policy is available and the counties, the health was devolved, the counties need to come together and bring in stakeholders at county level, both public, private, the mwananchi, and look at all the components of the healthcare system that address emergency care and look to build an emergency care system modeled around the WHO emergency care system framework. So we need to stop existing at individual components and actually look at bringing all these components under a system. And I think that's what the policy really highlights, is the need to build that system with every player contributing to developing a system that will actually save lives.
Okay, Dr. Benjamin Wachira, President of the African Federation for Emergency Medicine and also the founding director of the Emergency Medicine Kenya Foundation. Dr. Timothy Olweni, Secretary General at the Kenya Association of Private Hospitals. Commissioner Kagwiri Mbogori was with us earlier on. She had to leave for another meeting. She's a council member at the Kenya Medical Practitioners and Dentists Council. Dr. Ann Gathoni, who is in charge of Health, Environment and Sanitation in Lamu County. Nerima Were, Acting Deputy Executive Director at Kelin, and of course our creative Kevin Jue, who's a film director behind 18 Hours that reenacted the last moments of the late Madaga back in 2015. Well, that is the end of this conversation, and thank you so much for being part of it. I'm told there's some of you still talking to us in as far as your experiences in accessing emergency medical care. Eric Okioma says we need to have policies or guidelines, train and equip, motivate healthcare workers to effectively respond to emergencies. That has been touched on. Thank you. Amos Ruto says, we are losing lives due to lack of adequate emergency medical care. It is high time the counties direct their major funding to improving emergency medical care. These includes investing in ambulances, building hotspot hospitals, and reduce protocol in handling critical cases. Very well said, Amos. Shem Mwangi says the better thing is we still go abroad. Oh yeah. We still go to access these services abroad. Well, it's a matter of time when it comes to emergency medical care. So really, we need to think about investing at home. George Oduori, who says too many of these services are being delivered on TV. We hear you, George, but they are there. They just need to be accessible. Ruben says saying is one thing, doing is another. I agree. Evans Ayaga says we need to root out corrupt cartels that have siphoned funds meant for this. Evans, you have a point. Corruption is also a huge obstacle. Haraka here says, and this is the last comment for now, they will come out with charges that a simple mwananchi cannot afford. Hii Kenya iko na wenyewe and we are just slaves. Haraka, we hear your frustration, but as we are saying, emergency medical care, just like any other healthcare, should be accessible to all. Thank you for everyone who is part and parcel of this conversation. Thank you for your contribution. Tomorrow, we shall be shifting our gears and focusing on the joys and pains of single parenthood. Yes, we shall have single parents who've walked this journey and also trying to learn from each other in how this can be done to ensure that it is also easier journey for the parents, but also for the children that are caught in between. See you then.